The Dutch model of testing was really made to improve on the saliva testing model on a couple key points. So it's a dried urine test for comprehensive hormones. So the fact that it's a dried urine test is one advantage in that it's just simply a little bit easier for patients to collect a urine sample collected on filter paper at 4 times throughout the day instead of having to fill up tubes of saliva. That's really a minor point. The major point is in the comprehensiveness of it. A dried urine test for comprehensive hormones. We want to get more comprehensive with our androgens and our estrogens and reproductive hormones, but the most important point there is with the cortisol. So the Dutch model is simply more comprehensive. What salivary testing has that's excellent is the diurnal pattern of free cortisol, and that's really what's made it an improvement over serum testing for cortisol. What we find is that when you test urine at the right time points, you can get the same pattern of free cortisol. But we can add to that in ways that saliva testing just simply can't. So if you look at a patient that has low free cortisol in saliva, they have a similar pattern in urine in that the pattern of free cortisol is low. But what you find and what we find is that about 40% of these patients that have low free cortisol actually present with elevated levels of cortisol metabolites, which means their cortisol production is relatively high. The free cortisol only represents about 1% of the total. It's an important fraction, but the metabolites represent about 80% of the total. So when you want to ask the question, how much cortisol is the adrenal gland producing? The metabolized cortisol is really the better marker for that. So if you look at patients with low free cortisol and elevated levels of metabolites, you have low circulating cortisol, bioavailable cortisol, but you actually have an abundance of cortisol production. And to characterize well these patients with respect to cortisol, you need the free cortisol over time, and you need the total of the metabolites. Obesity is the classic case of this, where in obese patients, the production of cortisol is increased, and we see that in the metabolites. However, the metabolism or the clearance of cortisol is upregulated to an even higher degree, such that the free cortisol tends to actually go down in obese patients, leaving you with this dichotomous situation that you really don't even know exists when you're only testing the saliva. You need this Dutch model of testing to give you all of the information. So that's one huge advantage for the Dutch model of testing is comprehensive cortisol analysis. The other area where the Dutch model really excels over saliva is with estrogen for 2 reasons. One, we get to add into the picture again the metabolites, which is important for understanding the estrogens and if we're clearing the estrogens properly, and also as it may relate to certain cancer risks, which certain estrogen metabolites seem to be more protective of, and some seem to increase the risk of. The 2-hydroxy, the 4-hydroxy, the 16-hydroxy. We can also see the methylation pathway to see if people are methylating properly or if they may have nutrient deficiencies or genetic defects like MTHFR and COMT, which inhibit significantly the methylation. Moving on beyond that is the simple analytical accuracy of the test. When you look at salivary testing, the cortisol testing for free cortisol is accurate and works well. There's 10,000 times less estrogen than there is cortisol. And so when we look at this analysis, it really struggles to simply differentiate between low levels and normal levels and elevated levels of estrogens. We actually showed this in a recent study where we looked in serum and we looked at a group of postmenopausal women and then women who were in the follicular phase, which is the front half of the menstrual cycle, where the levels should be elevated above a postmenopausal woman, but they're not at the highest levels. We get higher levels than in the luteal phase, which is the latter half of the cycle. And then if we look in the middle of the cycle, when ovulation is happening, that's where you get those peak levels. So you get these 4 increasing levels of estrogen in these 4 phases of life. When we look at it in serum, we can see that. When we look at our urine test, we can also see that. When we look in saliva testing, those differences tend to shrink and disappear entirely for some labs. So with some labs, there's almost an entire commingling of these different estrogen states and levels, whereas with more sensitive assays, you start to pull apart a little bit the luteal from the postmenopausal women and then the ovulatory levels as well, which are even higher yet. but the degree of difference between postmenopausal women and luteal women, which is really what we're testing in the lab, is we're testing these women to see if they have this deficiency or sufficient levels. The difference is tenfold in serum, it's tenfold in our urine assay, and with saliva testing, it tends to be more equivalent or maybe different by a factor of 2 if the assay is a little bit more sensitive, but you really lack the accuracy to well differentiate these women in their different stage of estrogen deficiency or sufficiency. And as you bring this all together, a more comprehensive look at cortisol, a more accurate and comprehensive look at the estrogens as well as the androgen metabolites, you simply get a more comprehensive test that's more useful clinically to find the right answers for your patient's hormonal imbalances to properly treat them clinically.